I think another really interesting, trial that, may have implications down how we treat down the line was the sub-Q Nivo, right? So, we talk about nivolumab, we talk about Nivo-Ipi, we're talking about 2 years of intravenous administration. So we saw some really interesting data, I thought, on like changing the route of administration on nivolumab. I don't know, Libby, you want to?
Well, I think it's really interesting, and since COVID-19 has entered all of our lives, a lot of things have changed about the way that we administer treatment, about just the logistics of all of us practicing, and the concerns that patients have about more frequent healthcare contact, legitimately so. So the data was very interesting to see that and in that trial, patients received either every 2-week intravenous nivolumab or every 4-week subcutaneous nivolumab. And I think since that study has been was designed, most of us, I think, have changed over to our patients receiving intravenous nivolumab, receiving every 4-week dosing. However, but in that study, the PK data was pretty encouraging to reinforce the idea that this route of administration probably is safe and appropriate. And while certainly we don't have the same sort of long-term follow-up, and including about efficacy, and there were a few, there were some interesting questions raised about anti-drug antibodies. It was encouraging to see that this may be an available option for our patients. And they also, their presentation suggested that the subcutaneous administration was very tolerable for patients. And while I think right now it's unclear to me exactly what that's going to look like and who are the ideal patients for that. I practice in a catchment area where I have patients driving really long distances for treatment with me. We've implemented telehealth to a great extent. And so I think that there is a potential future in which perhaps home infusion companies can safely administer this while patients getting labs drawn by them and telehealth with me, which could be really patient-centered. And there's a lot of increasing data and interest in the concept of time toxicity for patients. Basically, what time patients, especially folks with advanced disease whose life expectancy, again, we hope is not limited, but currently the thought is that most of their life expectancy is limited to what it would be without the cancer. So being able to give patients control over their time, where they spend their time, home days as opposed to treatment days. And for some therapies, for some diseases, there is also data that subcutaneous administration really is impactful not only for the patient, but for their caregiver or support people. I remember reading something about sub-Q therapies. There's a meta-analysis showing that over the course of several years, patients' caregivers could get back more than 100 days of eligible work days. So I think this is really interesting. And while I don't think any of us in this room probably have exactly a roadmap for how we're going to implement it next, as soon as it's available, I think it's great to have more options for our patients.
No, I agree. I think ultimately at the end of the day, I think it takes doing a time and cost analysis to see what that's actually going to look like for patients, because, is the cost of this medication going to be way more expensive than the time saved? And, how much do you actually save? I think ensuring that the monitoring that's currently happening with administration of IV nivolumab continues to happen with the injection. This isn't just like an LHRH analog that you can give in the clinic without checking labs and just have a nurse just give it in your clinic and go. Like, you still need to check their labs, still need to check their LFTs, maybe their cortisol level, TSH level, and ensuring that those checks are still happening, that there isn't an opportunity for, to miss an event or something like that, I think is important. I think the ADA needs to get teased out a little bit. It was around 22% of patients who had antibody-drug antibodies, and so I think that could impact efficacy of the agents. And so I think we need to understand over time, what happens. And so I think that at the end of the day, it's a win to have another form of a drug that could be administered, but I think there's a lot of operational things that need to be discussed, and people probably above where we're at, our nursing team, our pharmacy team, our health systems, to integrate medication like that in the clinic.
Right, totally agree with all of that. I mean, it's not ready for Monday morning, and of course this was also studied as a single agent, and we're not really using much single agent Nivo anymore, but I'm all for giving patients more time back, right? If there's an extended dosing, I'm all for it because patients are anxious, right? They come into the cancer center and they're already at the edge of their seat when the doctor walks in, right? So whether it's a scan or just opening up labs, the patients are anxious and they also want the comfort of their time back. But I will say it wasn't for me a big differentiating factor because we already have 30-minute infusion of, I mean, that's relatively short compared to like GemCis, which is like 6 hours, right? They've also had subcutaneous rituximab, which, that saves a lot of time when you do it that way when you compare it to like a really long infusion of rituximab. So for me, it's an option, but it wasn't like a huge game changer for me.
Yeah, I mean,
And we need to
there's so
study
many
it with
factors,
TKI
right?
too. We don't have study as combination either.
I think so many factors. I mean, I do think that I commend like doing this, and not just because if you look at when we went from 2 to 4 week for Nivo or 3 to 6, that was all just on PK. There was actually no efficacy here. Actually, we did a prospective study, showed it, and we showed that in these patients with refractory renal cell, the PFS didn't seem to be different. So we saw some hints that like we weren't compromising any efficacy, which I think was really an encouraging thing to see with a novel agent. I mean, I think there's so many factors that come into play. I mean, I think the time is a valid one. Although I would argue, patients who need to get an infusion, it's not just 30-minute infusion. They have to go get an IV placed at the hard stick or this, or they get a port. Maybe you could avoid putting ports in some of these patients. So I think there's a lot of other factors. So I think it'll be really interesting to see how we can bring this in the clinic.
Yeah, absolutely.